The broadcast is now starting. All attendees are in listen-only mode.
Hi, this is Charles Reynolds. Thank you for coming tonight. There are quite a few people on the call tonight, and some of them are physicians who are already doing the procedure. Some of you may not know much about what the O-shot is and are here to find out if it might be helpful to you or someone that you love. I thought I would briefly go over what it is, 5 or 10 minutes, and then take questions. There are quite a few videos now out on the internet talking about the O-shot and what it is. There's a book out about it and quite a bit of science backing up the idea behind it. But sometimes I think I'm communicating when I'm not, so I think it would be helpful for me to go over the basics of it and then stop and hear what it is that still is um, questioning, bringing up questions for you, or as far as either providing it or considering it. So first, let's run through what the thing is. It's basically solving one of these problems. We'll get back to this. This is an interesting pathology, but here are the 4 basic problems of sexual dysfunction. And I think it's important to realize how important sex is to people's creativity, to their families, to their relationships. Emerson called it the scaffolding of love, and although big buildings can exist without a scaffolding, it's hard to renovate them and it's hard to construct them without that scaffolding. So I think we all recognize the importance of it, but it's useful to remember how important it is because it seems to be forgotten sometimes, and sexual medicine gets pushed aside as just something that has to do with having fun, even though one article in the Journal of American Medical Association showed that it causes serious psychological distress, and it's worse for women than for men. So here are the basic problems, and this is in the order that they would happen if someone was having sex. First, the desire to have sex. So desire is different from arousal. Desire means wanting to initiate sex. Arousal means once sex is initiated, does your arousal escalate? And the next, after it escalates to a certain point, is that followed by, or does it lead to, at least some of the time, an orgasm? And then last of the 4 different sexual dysfunctions in women is dyspareunia, or pain. And pain is this is pain that is not relieved by lubrication. So, and this is not from vaginismus. Vaginismus is actually lumped into this category now, but lubrication pain could be solved with lubrication. But this is pain no matter how much lubrication the woman has, she still has pain. And in one practice bulletin, which summarized the available treatments for these problems in the Green Journal, which is like the New England Journal for Obstetrics and Gynecology, a couple of years ago, offered only as far as if there is no surgical pathology, as in if the woman has no fibroids or ovarian cysts that are causing pain, if she has nothing that's surgically repairable, then the only Class A treatment, the only treatment that's proven to be of benefit and safe, is short-term use of testosterone. That's it, by a very recent article. And psychological counseling. But in psychological counseling doesn't take care of the problem. Of course, if there's physical pathology, it might make things better, but it doesn't make things well. So these are the 4 problems. And as an example of why this leaves a lot of people untreated, I had this picture, which I think is a very dramatic story. This, if you look here, this is a callus over this woman's clitoris. And this makes me sad to look at this. Thankfully, this story has a very happy ending. But this woman was using a very vigorous vibrator for a long time whenever she did want to have an orgasm. And having an orgasm with her lover was pretty much out of the question. And this is a woman who very much enjoyed sex previous to this. She's in her mid-30s when this picture was taken. And hormones are normal by the most modern ways of checking hormones. And I have here, she was in an abusive relationship. She was sort of tolerating a she was tolerating a relationship with someone that she wasn't that happy about, because she essentially felt sort of second rate, unlovable, because it was hard, very difficult for her to have sex due to pain. And once sex was initiated, it was hard for her to both have arousal because she's worried about the pain, and to have orgasm. So even by herself, to the point to where she had a callus here. There was no treatment for this before the O shot, other than hormone replacement, and topical hormones can sometimes help someone like this, but they had not been helpful for her, which left no other treatment. As another example of a type patient like this, a recent patient who saw me in her 20s delivered a 10-pound baby, after which she had urinary incontinence and painful intercourse to the point it was hard for her to have relations with her husband. And when we did the O shot, she was in the process of finalizing the legal paperwork of a divorce. And her gynecologist had nothing to offer. But within a month of doing the O shot, her pain was gone, her incontinence was gone, and she was back to having sex with her, by then, ex-husband. But now they're back considering reconciliation because they're having relations again because her body has been healed. So back to these 4 categories. These are the categories of sexual dysfunction in females for which every paper that's written about it begs for further research, because there's so little to offer the poor women who suffer with these problems. Estimated to be around 40%, and to be counted in these numbers, she has to be having physical distress. So if she's resolved her see, this definition must be causing distress. So if she's resolved herself to the fact that she's not going to enjoy sex and just decides to live alone, she quits being counted in the statistic, even though if she could be treated, you might argue that some of those women at least might choose to be treated. So it's the only medical problem I know of, really, in all of medicine where you're not counted if it doesn't bother you. If you have erectile dysfunction as a male, whether it bothers you or not, if you can't get an erection, that's erectile dysfunction. But the definitions are different with female. If you have pain with intercourse, if that doesn't bother you, then this doesn't get counted as a problem. So that's what the problems are as far as the sexual part. But in the process of doing this, actually, this woman was the first person who told me this. After treating her, her urinary incontinence got better. So how did that happen? I think this picture right here sort of tells the answer. Here's where we're putting this medicine. And the medicine is not really a medicine. It's just growth factors obtained from the blood. Probably should show you that. It comes from you centrifuge blood and get the platelets, and here's actually a microscopic picture of what happens. But this was a study of skin. Here's a breast that went from here to here, causing growth of the tissue of the breast, going from that breast to this breast within 2 months. And this is basically the same factors that your body would make to heal a wound. So you centrifuge blood, you get platelets. There's thousands of papers written about it. And the physicians who are doing this procedure have FDA-approved kits for preparing blood in a very sterile and methodical way so that you have platelets. And then those platelets are injected so that you get stem cell activation and regeneration of tissue. So where we're putting the shot is right in this area, which we call the O spot. There's really not a name for this place, this space between the urethra and the vagina. So we decided to call it the O spot. The G spot, thought up by Dr. Grafenberg, who was simply his idea that the urethra is very erotic. There's not much sensation in the vagina compared to the urethra, a lot of nerve fibers in the urethra. And he found by stimulating this wall of the vagina, by putting pressure here, you put pressure on the urethra, and that causes sexual stimulation. So that spot where you do that pressure to cause stimulation kind of varies from woman to woman. And wherever that place is that's most sensitive is called the G spot. It doesn't really correlate to a particular anatomical spot on here. It's just subjectively that's where the woman is most sensitive. And most women, it's somewhere in this area near the junction, the urethra and the bladder. But if you notice these little green things here, these are called Skene's glands or periurethral glands, and they secrete some fluid that tests positive for prostate-specific antigen. So this is like the prostate in a man. And when women ejaculate, they secrete fluid from this. They may also leak some urine, but they also secrete fluid from here, just like a man secretes fluid from the prostate when he ejaculates. So we think what's happening when of course, we haven't biopsied anybody's urethra after doing this, but we have clinical trials now that are near being published. And what we think is happening is when you inject this with the plasma, that it stimulates this to grow new tissue, just like it does with the skin and in the knee when it's used in orthopedics. And you get new tissue, new blood flow, it becomes healthier, and this becomes more responsive. So it would help both with incontinence and with the at least the part of the sexual function that is related to that particular organ. But there are other parts. I wanted you to see, let's look at all the different parts. Here's just sort of a scan of the table of contents of this book, Activate the Female Orgasm System, which I've put out just to kind of help explain it. And by the way, if you have Amazon Prime, you can borrow the book. They have a way where you can borrow a book on Amazon for free. So you don't even have to buy it. You can read it on Amazon for free, or if you want to buy the paperback version, it's $14. But if you go look at the table of contents, there's a digestive system, there's a circulatory system. Well, here I just kind of outlined the orgasm system. And you can write a whole book, and books have been written on almost every subject here in the system. But, if you can design, basically what system analysis allows you to do is think about how to make something better by thinking about the different components of it. So with the digestive system, you think about the pancreas and the bowel and the rectum and the salivary glands. Every part of that is part of the digestive system. Well, if you can think about all the different components it takes to digest your food and produce a bowel movement, I think it's worthwhile thinking about all the different components of your body that lead to the motions of love and connection and orgasm. And so I've made an attempt to put that here. Basically, it tells what the different components are the way I see it, but again, this could be expanded into many books, not just an outline. But the point I'm trying to make here is that each part of the system should be thought about. So within the past 2 weeks, I had one email from a woman who wants to meet me because her life was changed dramatically by an O-shot done by another provider in another state. And another email from a woman who said she had 2 injections with no results, which is pretty rare. So both of these ladies I have never met. So the woman who had no results, I don't know what happened, but I know that there's a lot more in the system than just the vagina. There's the pelvic organ stimulating center, the pituitary gland. You have these feedback loops. You have psychology involved. You have these different hormones. And there are many other hormones. The pituitary gland makes 280 something hormones. So these are just the basic ones. Testosterone, which helps with desire and orgasm. Thyroid for fatigue. Prolactin. If it's too high, it can make it almost impossible to have an orgasm. It causes fatigue and problems with depression, but the right amount can make things better. Estrogen, progesterone, oxytocin can make orgasms stronger. It causes uterine contractions. It can be taken as a nasal spray or an injection. There's literally an art to handling all these different hormones, and a really skilled physician knows how to do proper testing and adjust this so that things are better. And all the physicians who do the O-shot are either very well trained in this hormone replacement as well, or they're working closely with another physician who is. You can see there's blood flow, just like with the bowel. If there's different changes in blood flow, the bowel works differently as far as the digestive process, and the same applies to sexual activity. The Skene's glands we talked about, the urethra, nerve tissue, the clitoris, want you to see this picture of the clitoris. Most people don't realize that's the whole clitoris. What most people see when they're having sex or looking at their own body is this much of the clitoris, but the clitoris comes down, and this inner part of the clitoris is probably very important to sexual arousal and orgasm. But it's not thought about. A woman might have a 5-inch clitoris, 6-inch clitoris, but we're only seeing what would amount to the glands or the head of the penis when you pull the hood back and look at a woman's clitoris and the very top part of the corpus or the body. So imagine a man who could never have anything stimulated but the head of his penis. He might be frustrated. Or if only the head of his penis were activated. Well, when we do the O-shot, that plasma travels like a liquid all down through here, and we think part of the reason we're getting a good response in many women is it's rejuvenating this tissue. And you're getting, when I say rejuvenating, better nerve supply, better blood flow, and things are just working better. Again, this wouldn't work if the woman is upset because she's being abused and she has no hormones. This may not help her that much. On the other hand, if this tissue is not healthy and she's taking testosterone and it's a very loving relationship, things still may not work if this is not healthy. So this is just part of that whole system, and that's why I wanted to emphasize that in this book. And if you know, Amazon, they 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 cater to the idea that I think is very true, that the more you give away, the more you're rewarded. And so they do make it where you can read almost any book, and this one I have posted so that you can read the whole book about the O-shot. If you just find the Kindle version and borrow it, you can read it for free. Here it tells a story about the first one and more about how it works, which we just talked about, and then how it helps with urinary incontinence. And then this last chapter, I talk about different problems like pain, all those 4 different problems with sexual. We just talked about arousal and desire and incontinence, and even talk about fatigue and depression and how different recipes could be used as far as combining the shot with hormones and physical therapies. So that's a quick, really fast summary of what the O-shot is. And I want this out there so that basically I'll take this recording and encourage people to read this book for free. And hopefully it cleared up the idea for people who, or if you're one of the people on the call who just had no exposure to the O-shot. But I think I'm going to stop here. I could go on and on about this. Just one more mention about urinary incontinence, then I want to just stop and see who has questions, whether you're a patient or a provider. And if you want to go ahead and type those into the box, you can. But as far as the incontinence goes, I had one gynecologist say, well, shouldn't you do testing to see if it's stress or urge incontinence? Well, actually, we had some very promising results, excuse me, with both types of incontinence. But if you look at the available therapies, it's like the sexual part, there's a large gap. And here's what I mean by the gap. If you look, the first thing that people try are the physical therapies, Kegel exercises, avoiding drinking too much water, going to the bathroom frequently. Those are the physical therapies. If that doesn't work, the next step up is anticholinergic drugs, which have side effects, can make you feel fatigued and dry, and they're just not fun. Difficulty thinking, in an older woman, they can cause really problems with thinking. And there's nothing in between. Next up from that are injections. Here's one of the injections that are approved, coaptite. So I wasn't the first to think of injecting something in the vagina. The coaptite, if you look at here, this is the FDA paper on it. To get results, somewhere around 60% of people have to have 2 shots, but you have 41% have obstruction, they have urgency, and it's a pretty tough looking thing. If you look at the video on it, here's the video. I'll just show you a brief. It's like a toothpaste, so you can't just put it through. That's the needle they use. You can't just put it through a regular needle. It has to have this thing on the side because it's more like a slurry. So the point is, people say, well, I don't want a needle down there. Well, there's a procedure for the penis where people inject the penis with a shot just to get an erection. And a tiny 27 gauge needle is is smaller than what's used to drain the bladder of people who have obstructed bladders, a little needle's not going to cause a problem. But this big nail thing with a material going through it that's like a toothpaste, even though it's FDA approved, and I'm not saying it shouldn't have been approved because it was the best that was available when it came out, but 1 in 40 people who have this done by one study have to have surgery to have the knot removed that it makes. So what we're doing with the O-shot is much safer than what's available with this. Now, people will still need a sling and a mesh when that's needed. If you look at the pelvic floor, it's, let's see if I can get a picture here. The pelvic floor is made of muscles that you can't repair with just a shot like this. Here, this shows you here, there's this muscular sort of floor that holds the organs in. And if that's weak and the woman has a bladder that's falling out of her vagina, this shot is not going to help. But assuming she has, so there will still be a need for a mesh in people who need a mesh. There will still be a need for a sling in some people. All the things that the gynecologists are doing will still be needed. Nothing's going to go away. But that huge mass of people who are not being helped, and estimated somewhere around 50 million women in the US alone who are sort of stuck with no help, both with the incontinence part and the sexual dysfunction part. Here is something that is offering around 90% efficacy with practically a zero complication rate. There is nowhere in the medical literature that serious problems have been found with platelet-rich plasma because it just comes from the person's blood. So that's the deal. I think so let's stop now. And if you're someone who's interested in having the shot, the best thing to do would be two things. One, I would go see someone. If you go to oshot.info and then you click on here where it says find provider, then that'll give you a list and you can pull it up. I'm not showing favoritism. I'm from Alabama, which starts with an A, so that's why I came up at the top. But you can pick whatever state, put in your zip code. We've got a few different countries. Put in your country and find the person closest to you. Put in the zip code and it'll show the people closest to where you are. And just go see them, talk to them about it. It may not be the right thing for you, but if it's part of your plan to get well, the people that are listed here are all known by me and all known to be very quality providers, and you'll be handled properly. That's the purpose of this O-shot. I can't control the world, wouldn't want to try, but I can have a website where people that I know personally, people whom I have learned from, this is a group of doctors where we're sharing our knowledge with each other, learning how to make this procedure better. And that's part of what we're going to do with this call. In a moment, I'm going to quit talking and start listening and see what questions I can answer and what things I can learn from the physicians that are on the call that have been doing this procedure successfully and not successfully. Nothing's perfect. What are they seeing in the people that they're not able to help? But so the first thing to do if you're a patient is to go here, find someone that is doing the procedure and go see them. If they use the word O-shot and they're not on this website, then I don't know who they are. They shouldn't be using the name, and I don't advise you to go see them because they're using a name illegally, and I don't know what their qualifications are, and I'll have to see about that with my attorney. But if they're on this website, I know them and I know they're a quality provider. The other thing to do is just spring for $10. That's less than it costs for a couple of burgers at a fast food restaurant. Spring for 10 or $15. Get the book or get the Kindle book and just borrow it for free and read it and see if it sounds like something that be of help to you. Okay, so I'm going to stop there and let me just open it up for questions or comments from providers. There's so many people on the call. If I just unmute the call, I'm afraid it'll just be too noisy. Okay, so someone just said, okay, is the O-shot effective for women who have never had an orgasm through conventional sexual activity? That's a very good question, and yes is the short answer. Yes, emphatically yes. And one of the most satisfying things, I'll just tell you one story. I was in the office with a man in his late 60s, his wife in her early 60s, and he was just grinning ear to ear. They were there in follow up, bragging about how she had just had the first orgasm of her life. And again, think about the whole system. And if a woman has never had an orgasm ever, I found a lot of the times she's had testosterone levels that have been low. She could have something psychological that's bothering her deep seated. And I highly recommend that you consider also, if you go to the OSHOT website, I've tried to put here some very qualified sex educators. You can see it's a very short list. But this rabbi here has written a lot of books about sexuality. He's had prostate cancer. Dr. Watts, I know down the street from me in Pensacola, she's had the O shot. She'll talk to you firsthand about it. Emma Smith up in Boston, brilliant woman. She's working on her PhD. Veronica's written actually several books now. She's a very experienced therapist. Anyway, therapists are a good thing to do. Not so much about, even if you weren't abused, just kind of learning how to match the sexuality of where you are psychologically with you and your partner. But back to so I highly recommend that, highly, highly. But the other part of it is make sure the testosterone levels are normal and get the freaking O shot. Absolutely. The worst thing you're going to do is break even, but there's a very good chance you're going to see an improvement if you make that part of your therapy. And I'm hearing from many of the providers, they're seeing women in their 60s who are having orgasms and even multiple orgasms and ejaculation for the first time in their life. Any other questions? As far as the providers go, is there anything that any questions about the what you're seeing or anything that you would want me, because I'm videoing this and I'm going to post it. If there's anything that you would want to say about what you're seeing with the procedure, or what you're not seeing, or warnings, or anything that you'd want people to know about the shot. Well, I tell you what I would like to do. I appreciate the commitment of everybody that's here. If you'll shoot me an email and give me a mailing address, I think just for showing up, I'll shoot you a free copy of the book. Some of you I see are providers, and I'm already sending you a box of books because of our communications previously. But if you're a patient or a potential patient, wait a second, is the O shot? Okay, cool. Just got an email. All right, so I'll okay, exact location where to place the shot. Okay, that's a good question. Exact location to place the shot. I think the thing that's most important here is that water is going to sound silly, but water does not run uphill. And if you look at when you do the face, let me get to the vampire facelift. When you inject the face with platelet-rich plasma, oh, here's a really nice picture of the pelvic floor that the gynecologist will be very familiar with. You know, I never want to say I have a shot that's going to make surgery go away. Surgery is a natural therapy. You cut something out that doesn't belong, you sew something together that needs to be stronger. It can be a natural therapy, but it's not the end all be all for all problems. So that's a good picture of the pelvic floor and why you might need a mesh. But back to where to put the shot. If you look at the vampire facelift, out of which this sort of evolved, if you look at where you put the shot for the vampire facelift, it goes right. It goes, let's see, well, in this picture, let me expand it some. There. It goes, if you inject it right here, it flows up towards the corner of the eye. It doesn't flow down. In other words, it goes through the area where the tissue is most loose. It doesn't go through constrictions. So if you look at the anatomy for where the shot is given, back to this picture, let's see, here. If you put the needle way back here somewhere, the fluid is going to flow that direction, not this direction. And because this tissue is very thin, you can actually see this. If you're looking at the vagina head on, you can see there's a area here, and you can actually gauge about how thick that is. But it's not very thick. And so it would be easier for fluid to flow away from this area. So the needle should go up here close to the the opening of the vagina. And I do think the person who asked that question, I think, was making the point more than asking, because I think she's discovered, one of the physicians who's doing well with the procedure, that it does work better if you're up close. If you're back here somewhere, it's not going to work as well. And I guess you could make the point you would not need to do the injection into the clitoris at all if the woman just had urine problems and did not want to enhance her sexuality, but so far all of my patients wanted to take advantage of both. Um, let's see, what else? How many shots in total are administered? Okay, good question. So it's only 2 shots, one up in the roof of the vagina right there, which you just don't see pain from. It just doesn't hurt. Sometimes people will feel pressure, and I hate to say never ever, but you just don't see it. I've never seen it but once, when I saw a physician injecting his own wife and kind of missed here and wound up putting the needle there. But even that wasn't some screaming, jumping off the table pain, because she had numbing medicine, but she felt it. Most of the time, they don't even feel any pain at all right there. In the clitoris, so there's 2 shots. One goes right there, and the one goes into the clitoris. And that one is probably about 80% have zero pain, and another 20%, there'll be an ouch that goes away in a few seconds, just like if you had a regular shot. So it's just 2 shots. Now, if the woman wants to do something with the labia, I've had really nice effects, but this is more cosmetic, not functional. But I've had a few women who just wanted to plump up the labia and make it look pink and pretty, just like you do with the face. And so you can do extra shots in the labia of plasma, with or without some Juvederm, and plump things up and make it look pink. But as far as sexual function, it just takes 2 shots. Let's see. When you're in the right spot, do you feel a lump? Yep, that's a good point. Not always, though. When I put this shot here, there's so much volume that you'll usually feel a little lump there, but not always. The other thing I've noticed is that if you um, if you're back here, you're less likely to see it. It helps to actually visualize this go through. And if you look at a cross section of this, it's not like this wall is paper thin. There's some musculature to the vaginal wall. And so in theory, you could just be part way in and just be injecting the vaginal wall with plasma and not even be in the space. Or maybe you pass through the space and you're just injecting plasma into the urethra and washing out the bladder with plasma. But I I sort of hedge my bet with that, and I go through the vaginal wall, and then I go at an angle so that there's a lot of space. You can see if I were going crossways, there wouldn't be much traveling to get from there to there. But if I'm going tangentially, I can move the needle a long ways and still be in that space. So like starting an IV, I'll start right here, and as I'm injecting, I'll pass it maybe another quarter of an inch or so into the tissue, injecting as I go, so that I'm sure to get at least half the material right where it belongs. My guess is that you could probably get a really nice result with a fourth of the amount of material we're using, but I, because there's no side effects from it, I think it's helpful to use more than we need, just to make sure we get enough into the right spot. Let's see what next one is. Amount, okay, recommended amount, or cc's. Yeah, people use different ways to prepare the blood, and I've had good results with at least 3 different ways. I have a favorite way now that allows me to make more than I was in the beginning. In the beginning, I would only get about 5 cc's of plasma and got great results, and I really think that's all you need. But I have a way now to make more, and if I wanted to, I could put more around the sides, and also it allows me to concentrate the plasma from a larger volume, in theory getting more platelets. So there's more variables. Even when the doctor's using an FDA approved kit, there's about 20 different kits and variabilities in how they work. But the good thing is they're all FDA approved, and even though I have my favorites, the I have two, or actually three at least, that have worked very well, and the doctor should be injecting somewhere around 4 or 5 milliliters is how it be measured of platelet-rich plasma. I would want the doctor to be using an FDA-approved kit just for the sake of being consistent in the amount of plasma, that you know you're getting platelets and that you know you're doing it in a sterile way. Let's see what else. Any other? If injected with an excessive amount of volume, are there any drawbacks to the entire procedure? Yeah, that's the other fun thing is that, again, I've searched the literature. I've talked to biochemists and physicians who all around the world now that have used plasma. The only time I found anybody that even knew of any side effect from using platelet-rich plasma was a case in China where someone died, but it was a non-FDA approved kit. So the person died from infection from using a kit that was not sterile. But if the doctor's using and that's never happened in the USA using FDA approved kits. So if the person's using a kit that was designed to make blood to be put back into the body, you have the total amount drawn, even with my larger kit, where I'm getting more blood than I did in the early days. I'm still only getting about only somewhere in the order of 4 tablespoons of blood compared to all the blood in your body. And so if I use more, basically it's the equivalent of making a larger bruise, not the equivalent of injecting in a larger amount of some sort of pharmacological drug or some sort of filler like coaptite, where I have to worry about it causing an erosion or infection because it's a foreign body that's like toothpaste. Everything I'm going to inject is actually going to be resorbed. It's going to go away. And the long-term effects will be from the new growth that appears when the stem cells are fertilized by the plasma. So even though we have women that have really crazy hypersexual responses, I've had people that I've injected who've had orgasms walking in the grocery store pushing a buggy. Some have had orgasms just walking down the hall in my office, or one lady claims she had one hitting the speed bump leaving the doctor's office at the place where I trained another doctor. So, some really extreme hypersexuality, but that's just from the initial few days where there's pressure from that volume that I've injected. It's like the urethra is being stimulated all the time. But that completely goes away, and what you're left with is new growth that occurs based on the genetic code. So everything that's there is supervised by the genetic code that's in the stem cells. So the person grows normal new tissue. There's not a foreign body there. So there's no worries about putting too much. It's just getting it in the right place. And I think the problem has been in the past that we had materials that were not safe, and others who might have tried this technique have injected. Well, I can't find anybody that used plasma before me, but others who have tried before I showed them were going too far back, I think, rather than getting it up here where a lot of the pathology seems to be taking place. Anyway, the doctors that are on this OSHOT website are brilliant. They're they're committed. You can imagine anything new. Most doctors are afraid to jump out there and do the research and think about it. So they're committed. They're bright. Not everybody who wants to be on that website is. I learn from them. I highly recommend you see one of those people. Let's see. Here's another question. How long are the peak effects once administered? Was told it could last up to a year. The there's two effects. The initial effect, just from the volume that goes away, not from the actual growth, goes away in a few days. That's just from the plasma that gets resorbed. The initial effects from the plasma itself doesn't even fully take place until around 3 months, and doesn't even start until 2 to 3 weeks. So you're not even at full tilt until about 3 months out. Then, as far as how long does it last? Well, you know, you've grown new tissue, so you're not going to. It's not going to. I was trying to find a picture of a foot, a scar that I treated. I have scars that I treated that look better at a year than they did 3 months afterwards. So you're not stuck in time, but you've grown new tissue that then starts to age from that new set point, and that aging is going to take place based on what you're doing with your body and your own genetics, how old you are, and whether you're smoking or whether you're taking good care of yourself. The earliest I've seen it wear off was in a woman I treated for urinary incontinence, where she started to get a little trickle back around 9 months. But I have people that I've treated, most people I've treated haven't come back yet. And I started doing it 2.5, almost 3 years ago now. And most of the people that I've treated, it's still working. I tell people a year because I want to underpromise. And the sexual part seems to be additive. So in reality, what a lot of people do is they feel so good from the sexual part that they want another shot to see if they can make it better. But it's not because it's worn off. It's because they want to add to it. And but, realistically, for some people, like I said, I had one where the urinary part started to wear off around 9 months. And, it could be that it could be sooner than that. I just haven't seen it. But very frequently, it lasts quite a bit longer than that. Year to 2 years, I think, is still a very conservative estimate. Okay, I think I've kept you guys long enough. I hope that's helpful. I'll post this video if you want to see more of it. And if you want to shoot me an email or email me. Here's my email address. I'll put this in the thing. If you want to email to me your mailing address, I'll send everybody on the call a paper version of the book if you don't have one yet, just as a present for being on the call. Okay, thank you very much. I think this is a real adventure in medicine, and I'm honored that you guys are interested and are taking part about getting the word out. You guys have a good night.